Hey, thanks for the opportunity to present this talk. So I will be giving you a brief updates on some of the innovations in ALIFs and discuss some cases. These are my disclosures. None of them are really pertinent to this talk. So before we dive into what's new with ALIF, it's important to appreciate that ALIFs have been around for nearly 100 years now. So this is the original paper, one of the original papers on ALIFs from JBJS in 1930s, talking about Pott's disease and how to approach it from the anterior approach. You can see on that top right using osteotomes to take out the vertebral body. And with thoracic approaches, it got more popularized from the Hong Kong group in the 1950s. So in my practice, where do I see ALIF? So this is a 68-year-old woman, congenital lumbar stenosis, has a SPON-D at 3, 4, 4, 5. She has been miserable with this pain for some time. She has loss of lumbar lordosis, a pretty big mismatch there. So for her, there's a lot of different ways one can think to approach it. So she also has multi-level vacuum discs, no real coronal deformity there. So it could be a TLIF in somebody's hand, laterals, ALIF. You can also do an interbody where you can do a hybrid, meaning ALIFs plus doing a TLIF or a lateral. So there's a lot of ways to approach it. So in my hands, this patient gets staged ALIF 4 to S1 and doing a second stage with L2 to S1 PSF, instrumentation of the pelvis, doing posterior column osteotomies to release the spine. I did not have to do anything at the 2, 3, or 3, 4 levels for interbody. So this is her at about 6 months out now. So we restored the lumbar lordosis at 54 degrees, close to the mismatch numbers we like. And the jury is still out. The longer you do these, you'll know that maybe in 5 years something may change. But so far she's doing pretty well. So this is a 63-year-old woman, history of rheumatoid and lupus, back and leg pain. So this patient has an ODI of 46. So she is working, has been diagnosed with this RA for some time. Again, pretty miserable with the axial pain and also some radicular symptoms. So where I was in practice before at University of Rochester, I was there for about 10 and a half years. We really didn't have a lot of anterior approach surgeons. So the vascular folks were not too interested in that. So for a lot of these, I would be doing TLIFs or some type of posterior-based correction. So in my hands now, I'm doing 2-level ALIFs and then backing it up with perc screw posteriorly because we have much willing vascular surgeons where I'm currently practicing in DC. So for her, her ODI went down from the 40s down to 10, and she's very functional back at work. So what about deformity? So this is a 49-year-old woman, 37 years ago, had a T6 to L2 fusion for AIS. These are Drummond buttons that she also had, kind of sublaminar wires types. She actually followed me down from Rochester to DC because distally she broke down. So you can also appreciate on the sagittal MRI, she actually has almost a clipophile segment there of the lumbar spine at that L3, L4 level. So she's on the coronals here, you can see where that L5 is clearly tilted. She also has some foraminal stenosis. She's only in her late 40s, so it's pretty miserable with this. So, how do we approach this? Are we going to do a PSO, has been discussed before, a VCR, maybe a lateral corpectomy, ALIF, TLIF? So for her, she's going to get staged approach, so L4 to S1 ALIF. Then we did a TLIF at 2, 3. So you may ask, why not a lateral? So for her, she has a pretty big shark bite incision in her lumbar spine posteriorly where they took a crest. She also has a pretty big midline incision. So she really didn't want another lateral incision in her body. So that's why I listened to her wishes and did a TLIF, which worked out fine. We also didn't have to take down that Harrington rod there. We were able to work around and put screws around it. So far, she's about a year out and doing well in follow-up. So this transitions to, what is new in ALIF? So what could I have done different in that patient? Well, instead of doing the regular ALIF cages, perhaps I should have done patient-specific implants with 3D printed titanium implants that are available now. So this is a nice case report and 2 cases from the San Diego group with Mundus and ESLAC there. So they had this deformity patient. So for them, they ended up doing patient-specific laterals at L1 to L3 and doing L3 to S1 that are patient-specific to address their deformity. They got a pretty good correction, as you can see there. So there has been a larger series, multi-center, of individuals who do these, 67 patients. Most of them were actually T-lifts and laterals, but there's a subset that had A-lifts and lateral interbody fusion. So again, this is something to keep in mind for your practice, especially for individuals who have deformity. They had a 19% complication rate, but actually none of them were implant related. But again, follow-up is 14 months, so we'll see how that does. They did have 19% complications relevant to other pathology. So this is more something we see in our practice, which is like an isthmic spondy, right? So this actually spondylolysis eventually can turn to a spondy, but you can see that superior sacrum actually has a divot in it. Typically you see these with these dysmorphic sacrums. So typically in that red, you can see where a standard ALIF would go, but with the patient-specific implants, you can actually, again, customize it to that end plate. This is a study out of Seattle, but they actually used a company from Australia to get this device. This came out about 6-7 years ago now, but they were able to actually nicely match that end plate. And again, this is evolving, and as more adoption of this occurs, it's something that the turnaround for this, as far as ordering it and getting it back, will hopefully be faster. So moving on, somebody commented earlier with the Q&A about doing, perc screws or backing up a degen spondy. So this is a nice study from the Mayo Group. They actually answered the question: what do you do if? What are the outcomes of doing unilateral perc screws versus bilateral perc screws? So they had 60 patients, 27 had unilateral perc screws to back up the ALIF, and 33 had bilateral. Now the caveat is the younger patients ended up getting the unilateral perc screws. They did have, as you expect, a little bit longer op time in the bilateral perc screw group, but at the bottom line is, as follow-up, no difference in revision rates or screw loosening. Again, you have to choose the right patient for this. So this is one of my patients early on in my practice. She was 39, radiculopathy, disc herniation, so I did a discectomy on her. She did great, followed her for about 7 years, and 7 years later, she's coming back with axial symptoms, not as much radiculopathy. So, for her, especially with those two-level disease and how miserable she was with the 44 of the ODI, she ended up getting a two-level ALIF, but I just did the unilateral perc screws for her and did well post-op. So in conclusion, ALIF, as most of us know in this room and hopefully are doing it, is a pretty powerful tool to correct deformity, restore lordosis, and to also increase that neuroforaminal volume, so to get that indirect decompression. So the custom patient-specific 3D cages, I think, are here to stay, and we'll probably be seeing more of that adoption, especially some of the companies actually have opportunities for the hospital to get more reimbursement because of that device. The role of unilateral perc screws, I think, for selected patients is certainly there, and definitely larger series needed for that. Thank you.